Hi, my name is Dave Fitzgerald, and I work in the field of clinical psychology, specifically child clinical psychology. But in general, the broad field of clinical psychology deals with helping people kind of restore functioning. So there is an applied and restorative kind of perspective, which is different than some of the other fields, say maybe cognitive or experimental psychology. Clinical psychology, along with counseling and school, typically are those fields where we are working directly with people, trying to utilize the things we've learned through research and apply them in a practical way to help people. Specifically, what I do, I work in, as I said, the field of child and adolescent psychology. So I help direct a clinic here at University of Connecticut Health Center where we work with children and adolescents and families who present with different diagnosed disorders, things that you might find or read about in some of your other classwork. So depression, anxiety, ADHD, those sorts of things. And we work using best case understanding of research from what is empirically based, what is the best way to proceed with different disorders. So for example, earlier this week we worked with someone a teen who has obsessive compulsive disorder. The evidence shows us that the best way to proceed would be combining behavioral exposure and response prevention therapy along with medications typically in the class of SSRIs. So we've combined those two things and begun working with this teen to help reduce those symptoms so it's easier for him to go to school, get work done, see friends, and interact with his family during such mundane things as mealtimes without conflict. I hope that gives you some idea of the kinds of things that clinical psychology involves. Typically, it's going to be in terms of work. You would do your undergraduate work, then graduate school, and a year-long at least internship, sometimes followed by another year in postdoctoral training in terms of direct clinical care. All the while, during your graduate education, you'll have smaller, what we call practicums or practica, practicum experience where you're learning some of these things in smaller pieces. All right, well, take care, enjoy the class, and go easy on Dr. Roddenberry for me. Thanks very much. Bye.
I don't care what you think. I think that was an absolutely great intro. I know you heard the little echo. I've got 18 different microphones here in my office. Leanne giving me some crap. How are y'all doing today? That's my friend Dr. Dave Fitzgerald. I met him here in Cary. We used to play baseball together. He's a left fielder and hits with power from the left side. Absolutely fabulous guy. Oh yeah, and by the way, he's a clinical psychologist who used to work at Duke too. But more importantly, he's like I said, he's a home run hitter. But we're talking about clinical psychology today, and I wanted to introduce you to my friend Dr. Dave. I'm actually going to be referencing him a little bit later. And so I just wanted to go ahead and start with that. How's everybody doing today? We have a pretty good audience out there. Leanne, good to see you. Good to see everybody. So let's see. It's not as clear today, you would say? Okay, hold on. Let me see what's going on with my microphone. My audio is a bit weird. Okay. Huh. What about when I switch to this? Is my microphone a little bit better here when I switch to this? Is it any better or is it still bad? Same. Can you at least hear me though? I wish I knew what was going on. Let's see, Logitech. Okay, I'm just going to move on today, and I will have my microphone problem fixed by I don't know why. I'll have it fixed soon. Crap, 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 crap. Okay. I actually did buy a new wireless microphone that I'm going to start using next week. So hopefully we can talk about that. Okay, good. All right, so today we're going to talk a little bit about psychological disorders. That was my friend, Dr. Dave Fitzgerald. He specializes in treating developmental disorders. Okay, so he works with children. In developmental disorders, we mean things like learning disorders, anxiety disorders that you see in children, autism. He gives IQ tests every Friday. So he is definitely he specializes in treating those kinds of disorders that you're going to see in children before the age of 16 or 17. Okay? What we're going to do today is talk a little bit about clinical psychology and abnormal psychology. Now, this chapter right here explains to you the process of psychological diagnosis, the theory behind it, how it's done. And then it also explains to you several different groups of psychological disorders. Now, I think all of us probably know what is meant by an anxiety disorder. We all have a general idea of what depression is. So what I'm going to do this chapter is I'm going to focus more on maybe the part of this chapter that you don't know, which is how we provide therapeutic intervention. And then I'm going to talk about psychotic disorders on Thursday within the context of differential diagnosis. So I'm going to leave out some parts of this chapter. If you're interested in learning more about the details of anxiety disorders, the details of depressive disorders, the details of developmental disorders, then I'm going to direct you to Psych 281. In Psych 281, which is abnormal psychology. If you want the details of all the different disorders that there are. But in here, we're going to focus mainly on the model of how we diagnose psychological disorders. Okay? So, when you, remember we talked about subfields at the beginning of this semester, and subfields are no more important in psychology than they are here. In fact, not only do you have to specifically take schooling in the subfield, but for these three areas of psychology, you're also going to have to be licensed by state boards, okay? So I'm a social psychologist, but I've never been licensed, right? So I really, because there are no ethical, there are no medical, there are no psychiatric, there are no legal implications of anything I can and do say. But for these clinical psychologists, psychiatrists, and counselors, these people can diagnose people, give medicines, make statements in court. So they're not only trained within a subfield, but they then have to pass licensure tests. By the way, I do want to start off this class by alluding to that fact. If you look at the bottom of the screen in red, scrolling across the bottom is sort of a, if you will, my disclaimer. I'm a social psychologist, not a clinical psychologist, and I'm certainly not a licensed clinical psychologist. So anything I say in this class should be taken with a grain of salt. If there's anything that I say in this class that disagrees with something that one of your licensed professionals says, please, please, please take their word and do not listen to Dr. Roddenberry, okay? I have just enough information to impress a bunch of college freshmen, but I am in no way trained as a professional clinical psychologist. Clear enough? Okay, so there are three areas within the subfield of sort of this therapeutic psychology that you'll find. Actually, two, I should say, clinical psychologist and counseling psychologist. So there are three different people who provide therapeutic intervention. Your psychiatrists are actually not psychologists at all. Psychiatrists do not apply to graduate school in psychology. They apply to medical school, and they become doctors. And just like some doctors can specialize in feet, or in hearts, or in your GI, psychiatrists specialize in disorders of the nervous system. Okay? So psychiatrists actually aren't even really psychologists. They're medical doctors who specialize in disorders of the nervous system. You're going to see these folks at your hospitals, your psychiatric institutions. You're going to see them at bigger therapeutic centers than you'll see the other two. Now, clinical psychologists and counseling psychologists both go to graduate school in psychology. Okay, so your counseling psychologist will find a counseling psychology program, and your clinical psychologist will go to a clinical psychology program. All right, so there's a clinical psychology program over at UNC Chapel Hill if any of you are interested. It's a fabulous program, but it's extremely difficult to get in. Now, your clinical psychologists are going to go to 5 years of graduate school. They are going to conduct research on psychological disorders and treatment. And then they are going to do 1 year of a clinical internship where they're learning about a specific area of treatment. Now, they treat psychological disorders. They usually focus on an age group or a disorder type. So do you remember my friend Dave that you just met? He focuses on developmental disorders in children. So my friend is a child clinical psychologist. And so it's actually sort of unethical for a psychologist to provide a lot of therapy to someone who's outside their area of specialization. So it would not be appropriate for my friend Dave to treat an adult schizophrenic person. If he was to see one come through his office, he would refer that patient to another doctor who specializes in that area. Does that make sense, everybody? Okay, I know yes you are. Okay, now, so that's a clinical psychologist. Now, notice it says conducting research or on psychological disorders. In your typical PhD clinical psychology program, you also have to demonstrate an ability to do research. However, there are some people who say, why does a clinical psychologist who does nothing but therapy have to know anything about research? The APA says you do. However, recently there's a new sort of doctorate degree that's being given now that allows you to be a therapist without having to do the research training. So my friend Dr. Dave, he went to Notre Dame University for his PhD. He got the classic PhD, and he had to do a dissertation, just like all researchers have to do a dissertation. And then he also had to do his therapeutic training. Now, they have a new program called a PsyD. Okay, do you see that? A PsyD. Now, a PsyD is a terminal degree like a PhD, that allows you to hang out a shingle and treat people with psychological disorders. However, it just denotes the fact that you didn't do the research dissertation. Now, being quite honest, having the PhD is going to be a little more respected in the field than having the PsyD. Both of them can provide therapeutic interventions and call themselves clinical psychologists, but when you're going for jobs, the preference is going to be for the PhD as opposed to the PsyD, if that makes sense to you. And those are clinical psychologists, and they specialize in different areas. Now, counseling psychologists like you, Leanne, help people deal with what we call adjustment problems. And an adjustment problem is just a life difficulty that you're having trouble overcoming. So problems with environmental factors. So I may be a school counselor. I may be a relationship counselor. I may be a life counselor, if you will. And these folks are not going to treat the depression. They're not going to treat the anxiety disorders. They're not going to treat the schizophrenics. They're just going to treat the people who are having short-term difficulties with a situation or part of their life. So these are sort of the three groupings of helping professionals that you will see. Two of them are actually psychologists, and then the psychiatrists are medical doctors. Does that make sense? Clear enough? Clear as mud? Now, what defines a psychological disorder? Now, let's not talk about a psychological disorder. Let's talk about impaired function. We all have a certain level of effectiveness that we want in life. In our love life, in our personal life, in our professional life, and our happiness. We all want to experience well-being, but some of us have difficulty experiencing well-being. We have impaired functioning. And it's difficult to really pin down what exactly this is. It's a very shifting definition because what's energetic to you may be overwhelming and anxiety producing to me. What may be appropriate in this culture may not be appropriate in another culture. And so it's really difficult to pin down what it means to have a psychological disorder. Basically, what happens is a clinical psychologist, when you walk in the door, they listen to your presenting problem. Why are you here today? What's bothering you? And then as you're describing your situation, they're kind of looking for you to say one of or more of four things that will kind of give them a suggestion that maybe we need to go further and try to diagnose what's going on here. Okay, and the criteria by which we define whether or not you have a psychological disorder by whether or not it impairs your behavior, whether or not or your ability to function, whether or not it causes personal distress, whether or not it causes distress to the people around you, or whether or not it deviates from cultural norms. So when you go in there, the doctor's not looking at your symptoms per se in terms of trying to categorize you as to what you have. Instead, they're trying to see, are you having difficulty in any one of these four areas? So if you're depressed, so depressed that you can't get up and go to work, and you've lost your job and you're getting ready to get kicked out of your house, your experience is maladaptive. It's impairing your functioning. So we would say you have an impaired functioning, your psychological disorder. On the other hand, if you're so anxious that you are just really, really unhappy at the level of anxiety or depression that you have, and you feel sad all day and you don't like feeling sad, then we would say it causes you personal distress it causes you personal distress. If, however, let's say your thought processes are not matching up with everybody else, you're delusional, you're psychotic, you may not know any better, but it causes distress and it scares the people around you. Your parents are worried about you. Your brothers and sisters, your wife, your husband is worried about you. Then all of these are different hallmarks that you might have some sort of psychological problem. Now, the more difficult characteristic is actually the first one they talk about, the cultural norms. Sometimes behaviors that don't fit in with the expectations of society are called psychological disorders too. This one can be very, very tricky. You may or may not know this, but until 1973, psychology considered homosexuality to be a psychological disorder. And the only reason it was considered a psychological disorder was that it defied the acceptable cultural norms of the time. And so we have to be careful using sort of that fourth category. All right? Now, what causes, the first thing that people say is, why do people have psychological disorders? Who knows? Who knows? Who knows? Who knows? Psychological disorders are rooted in very complex things. People like to simplify it sometimes down to a chemical imbalance. Oh, I don't have enough serotonin. I don't have enough dopamine. Simplistic, simplistic, simplistic. Some people say, well, I was raised in a difficult house. Simplistic, simplistic, simplistic. Really, what causes you, because one person may be raised in a difficult household just like another person. One person develops a psychological disorder and the other doesn't. There are lots of reasons why neurotransmitters may or may not be secreted by different parts of your brain. Those causes may be genetic or environmental or who knows. So it's really complex. But your book kind of talks about two sort of broad ideas when it comes to psychological disorders. In looking at the etiology or the causes of psychological disorders, there is research to suggest that there are genetic factors associated with psychological disorders. We're going to talk about the genetic basis of schizophrenia on Thursday, and you're going to see that there's a strong genetic component to that. We do know that sometimes when people have brain trauma or lose parts of their brain, their behavior changes. Phineas Gage We talked about him in chapter 2. He's the guy who had the railroad spike driven up through the front of his brain. And suddenly he developed emotional problems and he couldn't control his temper anymore. This is a brain trauma. You know what? You're in the DSM that I'm going to be showing you, the Diagnostic Statistic Manuals of Psychological Disorders. You know what? They talk about temperamental and personality characteristics that are associated with all of the psychological disorders. This is the book that lists all of the different recognized psychological disorders right here. And this book suggests almost every disorder has risk factors that are related to early childhood personality and temperamental characteristics. Okay? And yes, so that's a good point. I'm sorry, I just looked down. I'm just looking at the comments. I'm sorry, I've been lecturing. You're not even paying attention to what you said. Very wealthy house, both parents educated. When they couldn't deal with the kids, they took them to psychiatrists. Yep, I could see that. They just didn't know how to deal with them. You know, right? And that's the difficult thing about psychiatric disorder diagnosis. There are not a lot of biological markers. In the interview process, the diagnostic process involves what parents say about you. So that could definitely happen at a, oh, is our stream lagging? Many serial killers weren't. So that's sort of one model. So, and then there's a lot of research to talk about income level and race in terms of incidence rates for psychological disorders. You know, there are gender differences in psychological disorders. As a general rule, men more likely exhibit what we call externalizing disorders, acting out kind of disorders, schizophrenia, psychotic behavior, overly aggressive behavior, and females tend to have higher rates of internalizing psychological disorders, that is, disorders involving anxiety or depression. So there are lots of factors that you can look at in terms of what causes psychological disorders. Now, one interesting model is called the diathesis stress model. And what these people wonder is maybe is it some sort of genetic predisposition? Why is it that two people will grow up in a difficult environment and one person will develop a psychological disorders and the other won't? And what the diathesis stress model is, it suggests that maybe psychological disorder, it represents sort of a genetic predisposition, and then childhood trauma. Now, this childhood trauma could be neurological, so it could be ingesting some sort of substance that's teratogenic in a way, along with a genetic predisposition, exposure to measles or exposure to some sort of virus. Or it could be childhood trauma in what we think of more as the classic sense of psychological trauma. But the idea is that we all have a genetic predisposition, and it really depends on that and a stressor to cause a psychological problem to develop. One copes healthier than the other. Well said, Judo. You might as well be teaching this class. Fabulous, fabulous. You know what? My throat is really, really sore today. I'm having some sinus problems, and it's causing a drip in my throat. Do any of you have sinus headaches? I have them all the time. I live with them, it seems like. Thank you for asking, though. Thank you very much. It's not coronavirus, I promise. Okay, so now a long time ago, the idea was that people who had psychological disorders were witches, and that's how we treated them, right? Back in the late 19th century, early 1900s, we treated psychological disorders by looking at people and trying to figure out what was wrong with this individual versus that individual, right? But the modern way of treating psychological disorders is what we would call the clinical model. It's where we go and look at collections of symptoms and try to figure out what symptoms you have and what these characteristic set of symptoms are. Emil Kraepelin was the father of modern clinical psychology. And he suggested, unlike Freud looked at individuals and he would try to describe the history of each individual. And the theory for psychological disorders was individualized. Mary had a psychological disorder because of her history. Fred had a psychological disorder because of his history. And so the way to diagnose psychological disorders in Freud's time was to try and look at a person's case history and the events that had happened in their life. Now, this didn't allow us to build any generalized model about what psychological disorder was or what caused it. Sort of the father of clinical psychology was this guy, Emil Kraepelin, who said, you know what, instead of trying to build a case history of a single individual, let's look at their symptoms and see if we can classify people based on the types of symptoms that they have. This is probably what you know of as the model for treating psychological disorders, but it wasn't always this way. But Emil Kraepelin was sort of the guy who sort of introduced this model, and his basic first classification system sort of was that we have disorders where people aren't thinking properly, they're deluded, they're psychotic, or people have disorders that involve emotions. That was sort of the original classification system that Emil Kraepelin came up with. And he was actually the first person to describe the symptoms of schizophrenia in a clinical sense. He called it dementia praecox, which was precocious dementia. And so he was the first person to describe the symptoms of schizophrenia. Now, going all the way from this guy's idea that we should maybe start looking at symptoms, what you have here in front of you is the DSM, the Diagnostic and Statistic Manual, introduced in 1959. This is the DSM-5. That means this is the 5th revision of this book. So every 10 years or so, they go back and revise it based on research, what we've learned about psychological disorders, diagnosing them, their incidence rates, their causes. And if we identify new syndromes or new ways of classifying people's symptoms, we update those in this book. So about every 10 years. The second one was in 1962, I think. The DSM-3 was in 1973. That's when they declassified homosexuality as a psychological disorder. And we're now in the 5th edition. Now, what's in this book? Well, the first chapter is called Use of this Manual. It tells you how this manual is organized and sort of gives you an idea about how one would use this as a desktop reference. Be forewarned, you are even less of an expert than I am. So you definitely should not be reading this book trying to diagnose yourself. Horrible, horrible, horrible thing to do. Instead, you go to a professional who knows how to use this book, okay? But the first chapter does sort of describe how this book is organized and what its use is. Now, the majority of the book, probably this much of it, okay, is going to be nothing but chapters filled with disorders that are organized by similarity. So, for example, the first chapter of symptoms is going to be neurodevelopmental disorders. So it's going to be all of the different disorders that you will see early in childhood. And these are the ones that my buddy Dave would be an expert on. And so each one of these chapters has a whole list, a family, if you will, of psychological disorders. You would be interested, it would be an interesting thing to read, Maya, but be careful. Do not diagnose yourself, okay? It's really easy to, because when you start looking at these symptoms, you're going to see yourself in half of these disorders. Don't diagnose yourself, okay? And then at the very back They talk about research issues that they're researching right now, and questions that they have that might influence the change that occurs in the middle part of the book, right? So every 10 years they revise the book. Well, they don't revise it out of nowhere. The back part of this book actually talks about the things that they're researching right now and the changes that they might make in the new book. For example, and I'm not a clinical psychologist, so don't hold me to this, but I think in the DSM-4, they had autism and Asperger's, which was a form of autism that was high-functioning autism that involved social impairments, but not intellectual impairments. Now, instead of having those two different disorders, they got rid of Asperger's disorder, and they have what's called autistic spectral disorder. So basically, they combined Asperger's with autism into one larger category. Okay, does that make sense? So, let's do now. What psychologists? Okay, here's the difficulty with psychological diagnosis. All right. Actually, let me ask you a question. If you had a broken arm, how would you diagnose that broken arm? How would you diagnose that broken arm? And I'm going to wait for an answer real quick. And X-ray. Good job. Good job. Okay. What would you do if you went into your doctor's office and your doctor didn't give you an X-ray? Instead, your doctor just felt your arm and asked you if it hurt and said, "Can you move it?" And you said, "No, I can't move it." What if your doctor said, "Well, I think it's a broken arm"? What would you think of that doctor's diagnostic procedure? Did that really blow out your eardrums? I got to get my sound right here. How would you like that? Unprofessional, absolutely. Well, how about this? How about this? There is no biological test for depression. There's no biological test for anxiety. There's no X-ray that measures psychosis or any of these other disorders that we may have. Basically, what you're doing when you're getting a clinical diagnosis is you're walking in there and your doctor's asking you questions, kind of like a medical doctor might ask you the questions I just mentioned, right? So there's really no biological process. I won't use my sound effects until I get my sound right anymore. I do apologize for that. Really, the clinical diagnosis procedure doesn't involve any biological tests that can truly confirm if you're anxious or depressed. And the other difficulty is sometimes these features are kind of muddy. The differences between these features are very muddy. So it's clear if you have a broken bone or you have a tendon tear, right? Those are two very distinct things. Well, different kinds of depression or anxiety have similarities and the categories overlap. So it's very difficult to diagnose psychological disorders. In order to do as good a job as possible, psychologists sort of borrowed the language and the concepts of the medical profession. Now, this still means that our diagnostic procedures are not as accurate as medical diagnostic procedures. I'm sorry. Unless you're clinical psychologists, don't tell your clinical psychologists I said that, they'll beat you up. But really, they're not going to be able to 100% diagnose these things because there's no biological core. Yeah, exactly. Do depressed brains look a certain way? Sometimes, in situations, maybe, but it would be expensive to see that. But there's lots of different kinds of depression, too. And when you're seeing, so you know what I mean? It's really difficult. Anxious brains. You know, you can measure arousal levels, but you can't really predict who's chronically aroused, actually. Those are really good questions, but it's really hard to see those. All right. So what we do is we borrow these terms and concepts from the medical model in order to get as close to being right as possible. I'm not saying that your clinical psychologists are hacks. I'm saying is they have limited tools and they have to do the best with limited information that they can get from a test, an interview, or an observation. Okay? Now, the presenting problem is what you walk in the door with, what you walk in and tell them that's going on. If you went to a doctor with a broken arm, your presenting problem would be, I fell and hurt my arm, it's swollen and I can't move it. Presenting problem, if you were depressed, you might go into your doctor and say, doctor, I feel terrible and I'm thinking I have suicidal thoughts. That would be your presenting problem. Okay, the doctor then goes and does an assessment, just like your medical doctor would do. The only thing is we're going to have to use the tools that are available to us. I'm going to interview you and have you tell me what's going on, right? And I'm going to get self-reports from you. Not only am I going to talk to you, if it's appropriate, I may talk to your friends, I may talk to your wife, husband, spouse, or other. If you're a child, I may talk to your school teacher. So I'm going to do interviews and self-reports to sort of get your story and everyone's story about what's going on. And then what I might do is I might observe you as well while we're talking and make my own assessments of what I think is happening with you, what your abilities are, what your disabilities are. And then I'm going to give you a whole host of projective and self-report personality tests. You remember those from last week? I'm going to give you some self-esteem tests. I may give you a personality test. I may give you a personality disorder test. I may give you a TAC test. I may give you a Rorschach or an inkblot test. There are literally 30, 40, 50 tests. I got tests for anxiety, tests for depression, tests for psychosis, tests for bipolar. I can give you all of these tests. And so what I'm going to do is I'm going to assess you as carefully as possible. I'm going to kind of do all of them. See, that's a good question. Ed asked a question, do all kinds of depression lead to suicide? No, there are 9 symptoms of depression, and suicidal ideation is one of them. And you will see suicidal ideation will also be a characteristic maybe in some other disorders as well. So the symptoms kind of cross from disorder to disorder, and you sort of have to look at the collection of symptoms and make the best guess. And that leads to my third statement, differential diagnosis. Now, Etta, it can be hidden or it might not be present, Etta. That's the thing. Not all symptoms will necessarily be present in every case of depression I see. As long as you have 5 of the 9 symptoms, you can be diagnosed with depression. But which 5 symptoms you have will differ from person to person to person. Does that make sense? Right, it's not always a feature, Leanne. And see, that's the thing. When I do the differential diagnosis, Keelan, I also have to find out what kinds of chemicals you're on, legal or otherwise. Because if your suicidal thoughts, ideation, is caused by some sort of substance that you're taking, legal or otherwise, then I might not diagnose you as depression. I might diagnose the problem as being some sort of drug-related problem, psychosis. Does that make sense? The difference, so I have 2 people that come in and both of them are thinking about suicide. One reports symptoms that are related to feeling bad about herself, depression, and the other person reports these suicidal thoughts within the context of taking a lot of drugs. The way I treat these 2 people is going to be different. The first person, I'm going to talk to them and try to elevate their mood by talking about the things that bother them. The second person, I'm going to get them off of drugs. So the differential diagnosis, I look at the symptoms and try to figure out what these collection of symptoms represent. Does that make sense? And the differential diagnosis is really, really difficult here because some of these disorders are going to look similar to one another. Have you ever heard of bipolar disorder, those people who go through depressive periods and manic periods? Well, sometimes when they're depressive, their behavior, they may look like a depressed person. But on the other hand, they may cycle through a period of mania, and there are some people who have mania that's so strong that it actually looks psychotic. They look like they might have schizophrenia or a delusional disorder. I saw a video of a lady who was so depressed that when you talked to her, she sounded psychotic, like she was schizophrenic. She was so depressed. And the weird thing is you have to sort of sort out these symptoms and try to figure out which category to put the person in. Okay? And differential diagnosis is very difficult when you don't have biological markers. Right? Okay, right, and sometimes bipolar is caused because you're a bipolar personality, and sometimes bipolar behavior is caused by the use of psychoactive drugs, right? And those are two, they may look similar in their behaviors, but their causes are completely different, right? Now, as part of the research process, we also know how often we see these disorders and in what sort of demographic groups we're going to see them. So, for example, upper middle class females are more likely to suffer from body image problems and anorexia and these other disorders. So we can see different groups and the incidence rates in different groups. I think the incidence rate for schizophrenia is 1%. And it occurs earlier in males than it does in females, so you'll typically see it in males begin to appear in the late teens, and for females it occurs in the late 20s. And so we sort of understand the incidence rate. And then the etiology, we typically try to understand the underlying cause, because that allows us to then treat said disorder. And just like medical doctors talk about prognosis, you go in with a broken arm, the doctor wraps you up in a cast and says, you'll be fine in 6 weeks. That's a prognosis, right? With clinical psychology, we also know, we also talk about prognosis. 30% of the people who take this, this antidepressant will experience an elevation in mood. If they don't, then we put them on this other medication, and 30% of them experience an elevation in mood. So we talk about prognosis. Okay? So we sort of try to use this terminology which allows us to be systematic in our observation of psychological disorders. And even so, diagnosing psychological disorders can be a difficult and tricky process. That's why you should never do it, I should never do it, and that's why clinical psychologists have to go through a year of clinical training after getting the PhD before they're allowed to do these diagnoses. And that's also why clinical psychologists are encouraged to work on an area of specialization. That's why my buddy only deals with children and not children and schizophrenics and bipolars and all of these other different disorders. Does that make sense? Now, just quickly, there's a chart in your chapter right here that lists all of the different categories of the DSM. We are not actually I'm not going to test you on these for the test. I just want to direct your attention to these, and each of these represent the chapters that you will find in the middle of the DSM. So after you get past the introduction, the first chapter is neurodevelopmental disorders, right? And then you go right past that, and then the second chapter, then you go to the I skipped over. I can't find the second chapter, but there's bipolar and related disorders. And so each of these categories right here represents a different chapter of psychological disorders that are identified. The neurodevelopmental disorders, for example, are those that you're going to see developing in childhood. Depressive disorders, you're going to see in its own chapter, which is different from anxiety disorders. There are disorders that are characterized by a splitting of the identity. Remember, we talked about the self in Chapter 3 and also in Chapter 12. There are psychological disorders involved in the loss of parts of the self or splitting of the self, and that has its own chapters. There are somatic disorders, which are disorders where people's conscious representation of their body doesn't match up with the actual physical, where they have a difficulty between their mind and their body. So, for example, conversion disorders, sometimes people lose a loss of function of a body part when there's no organic problem with the body part. Instead, it's stress related, and it causes some sort of physiological symptom to manifest. Personality disorders has its own chapter. There's a disorder related to sleep and wake problems. So, do you know doctors usually get kickbacks from companies for prescribing their meds? You know what? I do not know enough about the industry to make a statement that I would be willing to put on YouTube about that. Akeelan, much sexier in your head than your peer. Funny. Very funny. I like that. All right. And then the last thing I want to talk about before I let you go, is comorbidity. So one of the concepts that your book talks about, and there's a picture of it, so I just wanted to stop and identify that, is the idea that sometimes disorders that are completely unique tend to co-occur. So, for example, a panic disorder is when you have sort of these unwanted panic attacks that last for anywhere from 30 seconds to 2 minutes. And some people will have recurrent panic attacks. And so every time they leave their house, they may experience one of these debilitating 30-second to 2-minute panic attacks where their heart races, their breathing expands, they feel like the world is pressing down on them, they experience abject terror for 30 seconds or 2 minutes. Okay, so that's a panic attack. Agoraphobia is a fear of open spaces. It's a fear of leaving your house. It's a fear of being around crowds. Well, and it's completely different from panic disorder. Some people have agoraphobia without having panic disorder. But these disorders are typically seen as comorbid. That is to say, about half the people that have panic disorder will actually develop agoraphobia as well. It sort of comes along. It's an independent disorder, but it sort of tends to co-occur. It's a comorbid disorder. All right. So here's the deal. One last thing. I forgot to mention this before I let you go. In each of these chapters, basically, they're going to list these 6 pieces of information. So for each of the, let's say, each of the autistic spectrum disorder, they're going to list to you the diagnostic criteria and the diagnostic features. That's basically the symptoms. And then there's a section on prevalence, how often you see it. Then there's a section on developmental course. When does it appear? What does it look like? Does it get better? Does it get worse? Then they talk about the risk factors, which are usually the genetic factors or the environmental factors that cause the disorder. Then they talk about the differential diagnosis, which is other disorders that it looks like when you're trying to decide if it's this disorder or another disorder. And then if there are any comorbidities, they'll list that. So each disorder within each one of these categories is going to include these 6 pieces of information. And this is so the clinical psychologist has all the information on every disorder. Does that make sense? Oh, did I lose everybody or did I just lose Leanne? Did I just lose Leanne? That's about all I had to say today. Thank you very much for staying so long. Holy cow, did anybody get anything from this lecture? Okay, Leanne, I'm confused. What's her question? Leanne, what the heck is that? Is it possible for me to specialize in children and teens while being a counselor, psychologist? Absolutely, absolutely, Leanne. I'm sure you could specialize on counseling for a specific age group. I don't know the specific program you would go to, but I guarantee you that you could pick the area or group of people that you wanted to work with. Did any of this make sense today? Sometimes when you're looking at a camera, it's hard to see and you're not sure. Okay, fantastic. And you were able to understand me well enough, huh? I tell you what, I will fix the sound, and once I get that fixed, I will introduce my sound effects back in. If you don't have any questions, I'm going to go ahead and end this broadcast. Remember, we have, before I let you go, we have webinar A tonight. I want you to watch the 15-minute video of Gerald the schizophrenic. We're talking about differential diagnosis in class tonight, and we're going to be talking about how to diagnose different kinds of delusional disorders. I want you to watch the video of Gerald the schizophrenic tonight. Can you do that for me? All right. Take care, folks. Have a great day, and I will see you tonight in webinar.